This other is an LED system named HD-550, of course, LED, that has something very interesting for us. That is this, what I name bright chrome endoscopy, is SFI. And what is white become whitish. What is red becomes reddish. I really like this scope for its maneuverability. So we are here back in the second. This is, of course, the appendix. And usually you can retroflex quite easily, and you can have a synoptic view of what is the proximal colon. Ale, I know you really like this maneuver. And you can immediately see 1, 2, 3 polyp, and they are extremely well.
And you have chrome endoscopy for characterization?
Yes, Ale, of course, this is a pre and post processing.
Okay.
And this is named as VIST, and you can get close to the lesion, and then you can also apply an electronic zoom up to 1.4. And I guess, Ale, that we very well depict the pit in VIST. So this is blue light, but with some post processing. This really let you see the pit, but also
you can collect pictures from the side, no?
Yeah, absolutely. You can compare. This is a larger lesion.
You think you can remove this large lesion cold?
I would not do, because I cannot exclude that there is.
Can we risk?
Yeah, I mean, but I need to inject, and then we can try.
Okay. Little injection.
Can I do a little injection?
And what is the channel width of this scope?
The channel is 3.8, but you also have the 4.2, so you can have a choice in between. So if I see a lesion in retroflexion, and I can inject in retroflexion, I'm happy, because
maneuverability is very good, no?
Yeah, I really like the maneuverability of the scope. It took really 2-3 minutes to get to the cecum, and so let me find better position. Okay, please out with the needle. Okay, start injecting.
So for these type of lesions that you find in retroflexion, do you recommend always doing the first injection in retroflexion?
Yes, whenever I can. Okay, now I feel it's enough.
Okay.
Okay, needle in. Okay. Okay. Okay, let's move to white light now to see what we did.
That polyp were not easy to be seen. No?
Yeah, absolutely. And especially the smallest one, this one also. That. Okay, this was the first. Okay. Oh, but probably it's not.
You see how difficult?
Yeah, it is to retrieve the same polyp that we injected. Okay, here it is. Yeah. Okay, so I'm trying to put it at.
Normally, you go on the 6 o'clock, no?
Yeah, or anyway, what is left to right? Yeah.
So basically, you were able to push it into the a forward, so that you could see it in a forward view by injecting it in retroflexion.
Yeah. Yeah, you can try to remove in retroflexion, but
okay, I
think
we can give it a snare.
Can we have? But I need that a 20 millimeter snare or 15 millimeters snare.
No, 15. Also 10 millimeter. I think you can get it with a 10 millimeter as well.
Okay. Okay.
Which one is this? ¿Cuál es, quello?
12.
12. 12 is perfect. 12. Okay, try with the 12. Antonio. No.
Yeah, with the scope. Yeah.
Ali, how are you choosing? The size of snare?
So, very good question. So it looks like around 15 millimeter. So probably we can squeeze this in a 12 millimeter snare. This is going to be, I think, as a
Opening?
med work, typical med work
Yeah,
for
this is some
cold
med work.
snaring.
Yeah.
So and now, so it's
So
flipping around very nicely. You see, even though we think it's bigger, so this size of snare can fit nicely a little bit larger.
try to close.
Start close, close, close. Okay, just don't cut now. So it's typical situation now. You need to take a while, a little while, because you are having mechanical hemostasis. So and after about 10 to 15 seconds, you can go straight, cut. You cut it, okay?
Oh, that's nice.
So I convinced Cesare to
Yeah, you
make
convinced
this
me, Ale.
to make this
Yeah.
cold. So I would say that's been a great demonstration of going cold also for a sessile polyp. I think that up to 10, 15 millimeters sessile, we can still go cold.
Ale,
Very
did you
beautiful
clip or
resection.
no? No.
No, I would say
So
no.
you tamponaded a potential vessel by just strangulating it with the snare before you cut it through.
Yeah,
Exactly.
exactly. This is
Exactly.
what he does. Yeah.
Okay, I think we can move to Silvia Carrara to the US case. That will take 5 more minutes and we are done from Milano. Thanks
Great.
from this room.
Thanks.
Thanks for a great
Rita.
demonstration.
Bye bye. Grazie.
Hi there. Sylvia, we are
Hi.
with you.
Hi, hi. Hello,
to
thank
see
you very
you.
much for this invitation and thank you to all the equipe of the endoscopy room. So this is a 63 years old man with a new onset of diabetes, diarrhea and abdominal pain. He had a CT scan that show a lesion in the pancreatic head. But here I am at the level of the esophagus in the subcarinal space, and I want to show you this, which is a lymph node. And you can see how stiff is this lymph node. It's blue at the elastography, and the strain ratio is high. It's 33, 35. So I think that this could be a metastatic lymph node. This is the azygos vein, and this is the art. And you can see here other lymph nodes that may be pathological and metastatic lymph node. You see here how infiltrating is this mass between the esophagus, the aorta, and the spine here. So I go down now and I study the lesion from the stomach and from the duodenum. I'm using an Olympus endoscope, and as you can see here with the echo processor, which is the UM2, and this is a linear endoscope. Here I'm at the stomach. This is the splenic artery, the splenic vein, and this is the versum, which is normal here. And if I follow the vessel, I see the confluence, which is normal here. But posteriorly, you see this structure, which is a vessel, is the superior mesenteric artery, which is completely encased by the tumor. Siam is here, and you see how infiltrating is here the tumor. So the mass is here, it's a hypoechoic infiltrating. There are other lymph nodes also in the abdomen. So the encasement.
Silvia, the point is now, do we need elastography to characterize this lesion or we do not?
Yes, of course, this may help. If in case we see a lesion which is in the context of chronic pancreatitis, the elastography may help to understand how deep, how stiff is this lesion. And it's also helpful to study some lymph nodes. You see that the lymph nodes are mostly blue.
So based on this, Shyam, FNA or FNB, what do you suggest?
I think it's all solid masses. There's no more FNA unless you are on chronic anticoagulation. You have to go through a vessel. Then maybe we can use a 25 gauge FNA needle. Otherwise, all solid
So
masses.
this is a big take-home message.
Yeah.
So
Yeah.
no longer FNA.
No, FNA only for pancreatic cysts.
And what about the GIST?
Again, biopsy needles.
Okay.
This is a mass. You see this mass in the Uncinate process. The pancreatic duct was not dilated. Also, the biliary duct because the mass is deeply located into the uncinate
So Silvia,
process.
you're doing FNB?
Well, I'm using a needle which is from Olympus, the EZ Shot, which is a needle used both for FNA and FNB.
So you have the perfect solution. It looks
Yes, let's see. It's I choose a 22 gauge needle.
I think Sham approved, you know?
I think if you use the new generation FNB needles, it's enough to do 1 or 2 passes. This needle works very good, but it's important to perform 3 biopsies, and I think it gets done.
Yeah.
We have also shown in a randomized trial that when you use this particular needle or the Procore needle, you have to use suction.
Okay.
To get core tissue. If you just want a diagnosis, it doesn't
The
matter.
technique is a little bit different.
Little different, just because.
Yeah. So you see the
You
tip
can
of
show
the
us.
needle, and I mean, the tip is very sharp, so you can puncture. I'm here and puncturing the tumor, and we are using the slow pull technique. So the nurse, Monica, is withdrawing very slow.
And when you apply suction?
When you apply suction, you may have a little bit more blood. So usually we apply suction when you puncture cyst lesion. It depends on the technique.
I think if you don't have a pathologist in the room, suction doesn't matter. If you have a pathologist in the room, then when you use suction, it gets bloody. Then you start worrying. If there's no pathologist, it doesn't matter.
Okay, after showing this, we can move to George Webster video. Thomas?
Wow,
Yeah.
That's
There's
probably
a
a
lot
diagnostic tissue. I think you have a diagnosis.
There's a lot of mucus inside here, you can
yeah.
see. Usually we perform both cytology and histology if we have no rows. So I will prepare smear with this, and then we will put all the material in formalin for histological evaluation.
Congratulations,
There is
Silvia.
no blood, it's just
It's always
tissue.
fantastic. Terrific job. Thanks to both of you. We can move to George Webster. Thomas, if you're there.
Great pleasure for us to welcome you back
Thank you.
to University College in London. This is an unusual case, 75-year-old man who some years ago had a distal gastrectomy for malignancy and a gastrojejunectomy. He presents now with symptomatic bile duct stones. Conventionally, RCP is not feasible in this setting. He's had an attempt at endoscopic access via the jejunal loop without success. And so here we are taking a percutaneous transhepatic approach. We'll just see the initial cholangiogram here. Can we just screen, please? Small filling defects in the lower duct. He's had a previous 8.5 French internal-external drain inserted, and we're going to change that over a wire. And so we're passing a 11 French dilator over this wire. Screen, please. Now we're inserting 12 French Cook peel-away sheath, which we insert over the wire and through which we will insert the cholangioscope. So we're nicely in with the 12 French peel-away sheath. I'm going to remove the trocar and the wire, actually. Can I have a 9 to 12 Boston balloon with a 260 Jaguar down it? The stones on imaging are not large, but the mechanics of pushing stones antegrade down the bile duct are much less favourable than retrogradely pulling them down as we do at ELCP. And of course, so we've got quite a big team in the room today. I'm ably helped by my radiology colleague Graham and our fantastic endoscopy nurse Ira, and Ollie is keeping this patient safe with general anaesthesia. Just going to do a balloon cholangiogram with a wire down, just to see what we're dealing with here. That's nice. Keep injecting. Little stones there, probably just, you see that just below us. Take that picture for us, please. Stop there. It's interesting that we've got reflux back up the cystic duct. A few little stones there. Quite a low inserting cystic duct, actually. And then the other interesting thing is reflux back into the pancreatic duct, which we don't want to do too much of, even though we're not going retrograde. These patients have rectal non-steroidals to reduce the risk of post-ELCP pancreatitis. Down with the balloon, please. That's good. There's quite a lot of resistance getting through the lower duct, as I explained. pushing catheters antegrade down the bile duct is not actually that easy. Okay, so we're using here the new Spyglass Discover scope. It's a digital cholangioscope, very similar to the Spyglass DS2 from Boston Scientific. The advantage of it is that it's tailored specifically for percutaneous or transhepatic or even peroperative use. It's a much shorter catheter, 65 centimeters, which means handling of it is much more straightforward. And it's finding an increasing role for the small population of patients with particularly difficult anatomy that can't easily be resolved with biliary intervention using ERCP or perhaps EUS. Can I have a wire, please? Screen, please. So on the screen here you can see I'm flushing with normal saline. I'm within the 12 French peel-away sheath, and then just coming down the bile duct into the common hepatic. We can always pull that sheath back if we need to, depending on where the stones are. So you can see small stones immediately as we come into the bile duct. It's often interesting on cholangioscopy how many stones there are that are not appreciated in previous imaging, whether it be MRCP or ERCP. And we're going to use electrohydraulic lithotripsy to break up these stones. I'm then going to see if I can pass antegrade the Spy Discover scope through the distal end of the bile duct. We've become a little bit complacent, if you like, about the quality of the imaging that we get, but the image quality is outstanding. And these, of course, would have been stones that would have probably found incredibly easy to remove at a standard retrograde ERCP. But as I say, from experience, pushing those stones through can be quite tricky. And so we're going to break them up, then we're going to perform a balloon sphincteroplasty. So I've got the EHL probe out. I think it's quite hard stones, actually. Very nice. Yeah, that's broken up. We want to be careful with EHL not to hit the wall. Although I have to say that in well over 500 or 600 spyglass cases for stones, we thankfully never had any bleed or bile duct trauma or perforation. Okay, so that's cleared those stones. And just slowly make my way down the bile duct. Want to avoid putting too much contrast into the duct at this point, because you then get a very wavy appearance that can really obscure your view. The variation of biliary mucosa appearance is very significant. No doubt that sometimes in patients with stone disease the mucosa is completely bland, and in other cases there's a florid inflammatory response, and patients with that appearance seem much more likely to have associated inflammatory strictures and granulomatous change related to stones. And the same is true of PSC. Sometimes the mucosa is entirely bland, and other times it looks for all the world like small bowel Crohn's disease. What I want to do now is go in with 8mm sphincteroplasty, and then push through with the balloon, and then probably one last check with the cholangioscope. Good, so we'll just remove the wire. Again, this is another great advantage that Ira and I need to do only a very short exchange here. So if you push in and I'll come out there. That's good. That's good. I've got the wire. Then we come out with that. So we're going to do a dilatation of the sphincter, a balloon sphincteroplasty here. Let's inflate. 6, 7, 8. There's a bit of wasting there. Okay, good. Good. Take that picture, please, and we'll just hold that for 30 seconds. Okay, screen. Good. Okay, blow up again, please, to 12. Okay, and inject, please. Keep injecting. Nice. Keep injecting. Keep injecting. This is a down-firing balloon. which allows me to delineate what's above me. Okay, I think that looks really good. We're going to come out with this. We're just going to go in with a spy one last time, just to see there's no mischief. Happy? We're connected up, aren't we? We're good to go. Okay, so going nicely down the duct now. All looks much clearer. We come down antegrade down the right duct. When we get into the common hepatic, this is where we see this very abnormal mucosa, inflamed, ulcerated. Much as we think we're very good at making a cholangioscopic distinction between benign and malignant, and if you looked at this, you might say, well, look, there's quite a distinct cut-off between normal mucosa here and then abnormal mucosa here. We need to look at the clinical context of a patient with stone disease, no particular stricture, and having had an external biliary drain through this area. But we will, for completeness, just biopsy this area so there's no concerns raised. Close. Thank you. The new SpyBite Max biopsy forceps have got rather sharper jaws than the previous version, and I think provide better bites. Lots of stone debris in the small bowel now. Yeah, that's a really good view of the lower duct. No residual stones. That's a beautiful view. It is inflamed. That should all settle down now that the stones have gone. Coming all the way back, so we're done. So I think it's a good result.